So let's continue with the second part of approach to developmental delay. In this video, we will be looking at clinical examination in a case with cerebral palsy. How do you investigate the case? What are the treatment options available? And we'll also have a discussion on cerebral palsy with the commonly asked Viva questions. So uh, at the end of the part one, where we looked at the history taking in a case of developmental delay, we were able to summarize this as a case of cerebral palsy, which is a non-progressive or static encephalopathy presenting predominantly as a motor disorder. Okay, so that was how we were able to, at the end of history, diagnose this as a case of CP. And then there are different types of CPs, etiology, and associated comorbidities. All of this we have discussed. So moving ahead, let's go ahead with the examination part. So general examination, first, most important is what is the nutritional status of the patient. So just a first look of the patient will, give you some idea whether the patient is well or undernourished. So we all know that, patients with cerebral palsy have feeding difficulties. They have swallowing difficulties. They have pseudobulbar palsy, and that's why with the feeding difficulties, they can be undernourished. That's why just a look of the patient, whether you feel that the patient is well or undernourished, is important. What is the posture? So, contractures is a very common complication that we see with cerebral palsy, the spastic variety. And so, a lot of them, if haven't received adequate physiotherapy, will be in a state of, contracture. So, they'll have contractures in either the upper limbs, lower limbs, most commonly involving the elbows and the ankles. So what is the posture of the patient? Is the patient uh, flexed, or does he have any obvious deformities, any obvious contractures? Just on examination is what you mention in your posture. Next is vitals, like any other case. So you mentioned about the temperature, heart rate, respiratory rate, blood pressure, CRT, saturation, and peripheral pulses. Now in anthropometry, again, this is important. So like any other pediatric case, you look at the height or length, weight, head circumference, BMI, and your weight by height. So that will give you an idea at the end of interpretation as to what is the overall nutritional status of the patient. What is important is that a lot of these patients who have cerebral palsy or who have developmental delay have feeding difficulties. Now, they're often failure to thrive or they're underweight, undernourished. Now, failure to thrive in a patient with CP could be either because of feeding difficulties, like I said, because they have a spasticity, they have involvement of the lower cranial nerves, which is called a pseudobulbar palsy. We'll be looking at that later in more detail. So they have feeding difficulties. And other thing that could, probably point to why the child is failure to thrive is could be underlying torch group of infections, chromosomal anomalies, genetic causes, inborn errors of metabolism, or just purely nutritional that nutritional supplementation is not adequate. So these are the causes of having failure to thrive in a case of CP. So just to revise, causes could be feeding difficulties, uh, underlying torch infections, chromosomal or genetic causes, inborn errors of metabolism, or purely nutritional. Now, we just discussed that in posture, a lot of these patients have contractures. So then how do you measure the length or the height in that case? So that's something called as segmental length, especially when you have contractures. So because you're not able to straighten out the limbs completely, you measure the length in segments. So let's say the child has contractures in the knee joint. So the knees, the limbs are flexed at the knee. So you're not able to strengthen it to take the length. So what do? You take measurements from the pubic symphysis to the knee, and then you measure from the knee to the ankle, and you add it up. So that is what is called segmental length of the lower limb. So you add that length with the upper limb, with the upper body length, and that's going to be the length of the patient. So it's a little tricky sometimes to measure length in these patients, especially if they have contractures, but you need to take something called as segmental length. That's something important to remember. Now, next in the head-to-toe examination. So first you talk about parallel ictyocyanosis, clubbing, edema, lymphadenopathy, like any other case. What is pertinent to a CNS case is the head examination, which is very important. So, sorry, is there microcephaly? So in head, exactly what examination, what do you look for? So you look for the head size. So microcephaly, abnormal head shape, deformational plagiocephaly due to prolonged immobilization, pressure alopecia, overriding of sutures. Now let's just look into detail as to what I mean by each of these. So when I say microcephaly, remember these are again important Viva question. What is the definition of microcephaly? So when the head circumference is less than -3 standard deviation, that is called as microcephaly. Now you can have two types of microcephaly. It can either be primary or it can be secondary. Why is it important to differentiate? Because the causes are different. So if you have primary microcephaly, it looks like this. So they have a receding forehead, they have occipital flattening, and they have predominantly large ears. This is what a primary microcephaly looks like. What is the most distinct feature is the receding forehead. So if you see that kind of uh, forehead on your examination, then it points more towards primary microcephaly. And always remember that primary microcephaly will always be present at birth, and it's because predominantly it's because of genetic causes. Whereas secondary microcephaly just have a comparatively smaller head. They don't have this particularly receding forehead. Uh, Secondary microcephaly can either be seen at birth or within the first 1 year of life. That's because the causes of this could either be prenatal or postnatal. So it could either be like a torch group of infections, or it could be CNS insults, hypoxia, meningitis, encephalitis, metabolic causes like hypothyroidism, or your phenylketonuria. All of these are causes of secondary microcephaly. So it's important to carefully look at the head shape and the size to say whether there is microcephaly, and if yes, then what do you think? Is it pointing more towards primary or secondary? Now, another differential diagnosis of a small head other than microcephaly is what is called as craniosynostosis. So what happens here is that the head is characterized by abnormal head shape. And why does this happen? That's because of premature fusion of the head sutures. Now, they will have overriding or ridging of sutures when when you palpate the skull, there'll be ridging of sutures in craniosynostosis. So that is a differentiating feature between microcephaly and craniosynostosis, both of which present as a small head size. That in craniosynostosis, you will have abnormal head shape and you'll have ridging of sutures. Now, just to give you an example of what different head shapes are, so you have scaphocephaly, trigonocephaly, plagiocephaly, brachycephaly. What is more important or what is more commonly seen in a case of CP is plagiocephaly. So what happens because these kids are more immobilized, they're not able to, sometimes even lift their head up. So they're continuously lying on the bed, as a result of which there's like pressure on one particular side of the scalp, which causes that deformation. So that is called as deformational plagiocephaly. So that's one thing to look for, and it is that's why when they develop this kind of plagiocephaly, the kind of treatment given is positioning the head so that the pressure on that particular one side is relieved. Okay, so we saw microcephaly, abnormal head shape, that is craniosynostosis, deformational plagiocephaly, pressure alopecia. So the part of the skull that's continuously in touch with the bed or the bedding, okay, that area develops alopecia, so there's loss of hair in that particular region. So that is again indicative of the fact that there's continuous, exposure, or this continuous surface contact of the head with, you know, either the bed or the floor, and that needs to be taken care of with occupational physiotherapy. So when you look at the eyes, so after head, next important examination would be eyes to look for cataract, squint, ptosis, coloboma, nystagmus, and Bell's phenomenon. Okay, so cataract, like for example, torch infections, rubella, can lead to CP, does have cataract. Squint is another important examination that we'll be looking at when we see the cranial nerves. But squint does give you a lot of information, especially in these cases. Uh, Coloboma is again associated with certain genetic or chromosomal anomalies that again can lead to CP. Nystagmus, so ataxic CPs, which have involvement of with the cerebellum, can have nystagmus. So these are important things in the eyes that you would want to look for. Facial dysmorphism, again pointing towards underlying genetic or chromosomal causes. Oral cavity, very important. Look for hygiene, dental caries, and drooling. So because these patients have spasticity, they have feeding difficulties, they always, not always, I shouldn't be saying that, they very often have poor oral hygiene, dental caries, and drooling. Okay, so when you say drooling, there are grades of drooling. So grade 1 is that there's no drooling. Grade 2 is mild, it just falls over the lips. 3 is moderate, where the drooling is up to the chin. 4 is severe, where it falls onto the clothes. And grade 5 is profuse drooling, where the saliva falls onto the surrounding objects, like on the hands, the floor. So drooling is again another commonly associated complication or comorbidity, as you might call it, in a case of CP. There are grades of drooling, and so when that is that so when drooling is something that the parents common or often complain of. So physiotherapy, occupational therapy needs to be done for oromotor stimulation to take care of drooling as well. Okay. Neck torticollis or stiffness, limbs, whether there's any obvious atrophy, diffuse atrophy, scissoring. So scissoring is seen in spastic diplegia because of spasm of the adductor muscles. So if there is particularly scissoring of the lower limbs, then that is sometimes very, very predominantly seen. Leg length discrepancy. So if there's hemiplegic CP, the limb on the affected side, because of disuse atrophy, might appear a little shorter as compared to the other side. So that is something that needs to be considered, especially if you're dealing with a hemiplegic CP. Now, hand regard. Hand regard is, so what is hand regard? So if you put a child in the supine position, say on the bed, what they do is at around 4 or 5 months or 3 to 5 months of age, they get their hands in front of their eyes, and it's like they're looking at their hands and they're understanding that okay, this is a part of my body. So that usually disappears by about 5 to 6 months. So if there's okay, that again is an early sign of cerebral palsy. Similarly, early handedness. So handedness, whether the patient is left-handed or right-handed, usually develops by about 2 years of age. So if a child develops handedness, let's say by 12 months of age, he tries to do everything with just one hand, lifting stuff, throwing things. Let's say the patient is, or the child is only using the right hand. So early handedness again will before 2 years of age is an early sign of CP. So neurocutaneous markers, you look for calcium spots, spot wine stains for neurofibromatosis, spot wine stains for Sturge-Weber syndrome. Look for BCG scar, any obvious spinal deformity. Bed sores again, because bed sores are something which is very important on examination because it is a common complication in cases of a CP where the child is bedridden and has impaired mobility. So it's common, it's troublesome, and that is why positioning the child, especially who has severe contracture, severe spasticity, is very important so that you prevent these complications of bed sores, especially on the pressure points like the shoulders, the buttocks, the scalp, etc. Genitals and joint contracture. So joint contracture examination is again something that needs to be given a lot of importance, and we'll see that in the next few slides. But never forget to mention examination of contractures in your head to toe. So we saw microcephaly and cranial. So contractures basically is more common in the ankle and the elbow. So these are two places where you have maximum contractures. Obviously, other limbs can also be affected, but you will first see them in these two places. So when do you say there's contracture? So when the movement is less than 10 degrees across that particular joint, that is defined as contractures. Now, most important is what are the types of contractures and why is it important to differentiate the two? You can either have dynamic or you can have static contractures. Now, what do I mean by both of them? So in a dynamic contracture, when I flex the proximal joint, there's increased range of movement. So let's say there is I'm suspecting contracture at the ankle joint. So if I flex the proximal joint, so let's say I flex the knee. When I do that and the range of motion across the ankle increases, then that is called as a dynamic contracture. Whereas static contracture, you will not see any change in the range of motion even when I flex the proximal joint. Another way of differentiating it is there's something called as R1 and R2 movement. So R1 is where you do slow movement across the joint. R2 is when you move that particular joint with speed. So what happens is when R1 is greater than R2, it suggests the dynamic contracture. So that means when the range of motion is more in slow versus fast, it points towards dynamic. Whereas if it's equal, it is called a static contracture. Now, why am I ranting so much about why is it important to differentiate between a dynamic and a static contracture? The reason is that treatment options available for both are different. So if you have a dynamic contracture, it is easier to treat, it has better prognosis, and you can treat with physiotherapy uh, predominantly, and a lot of it gets corrected just with that. Or you can also inject botulinum at the local site, which will again help in relieving the contracture. Whereas if you have a static contracture, as the word suggests, static, it's more severe, and the only way to treat a static contracture is surgery. So this is how you evaluate a contracture depending on the range of motion, R1, R2, and what happens when you flex the proximal joint. That's how we differentiate a dynamic from a static contracture. And it's important to differentiate the two because the treatment options available are completely different. So obviously you would want to catch a contracture in the dynamic phase, not wait for it to go to a static phase because it's easier to treat if it's a dynamic versus a static contracture. Okay, so this is an important thing. It's a new thing to remember, but it's important to evaluate, especially in terms of the comorbidities that these contractures can cause. So after head to toe examination, let's go to CNS. So the first thing is higher mental functions. So there's a whole set of assessment that you can do, or you have to do when it comes to assessment of higher mental functions. But because a lot of these patients with developmental delay have impaired, uh, impaired, say, language, motor, and social, milestones, it's not possible to assess all of these headings under higher mental function like memory, insight, emotion, etc. So what you need to emphasize on is what is the level of consciousness, what is the behavior. So sometimes these patients have emotional ability, so they're crying at one point and then immediately later you see them laughing. So whether they have any emotional ability, what the behavior is, are they very violent, are they very aggressive, what is the speech like? Are they able to communicate with the parents? Is it a spastic speech, or is it that a speech is severely impaired? So, important points to mention when you're assessing higher mental functions is the consciousness, appearance, behavior, and speech. Moving ahead with the cranial nerve examination, first one being the olfactory. So you assess for smell. Again, this is a difficult, or I would say hardly ever done examination, especially in kids, because they will not be able to tell you unless and until it's an older child with preserved mentation. So let's move to the second nerve. So when you have the optic nerve, you look for visual So basically, these are headings that you will want to evaluate in a patient when you're looking for assessment of the optic nerve. So you will look for visual acuity, color vision, visual fields, reflexes, and fundus. Now, for visual acuity, color vision, all of this, you require comprehension by the patient and communication coordination. Now, that often doesn't happen in a case of CP. So, what you need to look for is the reflexes. So, you look for pupillary reflex, and most importantly, you look for fundus. Why is it important? Is because if the child has impaired vision but has a normal fundus, then you would put the diagnosis as cortical blindness. That happens when you have the occipital lobe involvement, most commonly like in a case of hypoglycemia. So when hypoglycemia has caused damage to the occipital lobe, the patient will have vision impairment. However, the fundus will look normal. Okay, so that is when you put the diagnosis of cortical blindness. Number three, four, and six nerves. So you look for obviously any squint. So you look for alignment, movement of the eye in all the four quadrants. Whether the squint, if present, is it paralytic or non-paralytic? Nystagmus, pupillary size and reaction, and accommodation reflex. Now, just to mention a few points about squint. So, how do you assess for squint? So, what you need to do is you need to shine light into the eyes, and the light needs to fall at exactly the same position in both the eyes. Okay, it needs to fall at, let's say, for center of the iris when you're flashing light into both the eyes. That's where it's supposed to be normally. But let's say when you're flashing light, it falls at two unequal positions on both the eyes, then that is called as eye misalignment, which is pointing towards squint. Now, how to differentiate whether the squint is paralytic or non-paralytic? So there are a lot of tests like the cover, uncover test, etc. But the easiest way to assess is if the eyes are moving in all the four quadrants. Okay, then most likely it is a non-paralytic type of squint, which is anyways the most common type of squint that you see in a case of CP. Okay, so if the child has squint, but the eyes are moving in all the directions or all four quadrants, then the squint is called as non-paralytic squint. Why do you have squint in patients with CP? It's because of muscle and coordination, and often there can also be subcortical ocular motor cortex involvement. So these are common causes why you can have squint in a case of CP. So remember, when you shine light and it falls at two different points in the eyes, it suggests squint. And to differentiate whether it is paralytic or non-paralytic, you need to look for movement of the eyes in all the four directions or all four quadrants. So trigeminal nerve, sensations over the face. For motor assessment, you look at the muscles of mastication and corneal and jaw jerk. So again, sensation of the face might not be possible in younger kids or those who have impaired mentation, but you can always do your reflexes. Facial nerve, you look for facial symmetry, sensation, and taste. Now again, facial nerve examination is something that I don't want to go into detail because it's something that uh, I'm assuming everybody knows. And there will be a different video where I'll only be talking about CNS examination. So I will cover all of that in that video. Vestibular cochlear nerves, whether the hearing is impaired or not. So again, how do you test it? If the patient turns head towards the source of sound, then it is a corroborative finding that there is there is no involvement of the vestibular cochlear nerve. On the ninth and tenth nerve, you look for the position of the uvula, whether it is central or not, gag reflex, and whether there's difficulty in swallowing or drooling of saliva. Now, when I say that, let's say the patient has drooling of saliva, difficulty swallowing, coughs while feeding, has poor gag reflex. So, what are the causes of involvement of the lower cranial nerves or the ninth or tenth cranial nerve, particularly? So you can either have bulbar palsy or you can have pseudobulbar palsy. Again, this is another Viva question that is commonly asked in both pediatrics and medicine. How do you differentiate the two? What are the causes? So bulbar palsy is a lower motor neuron lesion or an element lesion. Whereas pseudobulbar palsy is when you have involvement of the corticobulbar tracts. So that's a UMN lesion. Okay. So that's the first differentiating feature, that this is LMN versus pseudobulbar being UMN. Now, because I'm saying bulbar is LMN. So in LMN palsy, you have depressed reflexes, so you will have absent jaw jerk. Whereas in the pseudobulbar palsy, you will have a brisk jaw jerk. And again, because this is a LMN lesion, your tongue is going to be wasted, flabby, with or without articulation. Whereas the tongue is going to be small and spastic in a case of pseudobulbar palsy. Okay, so pseudobulbar palsy is more commonly seen with CP because there's involvement of the corticobulbar tracts. It's a UMN lesion, and that is the most common reason why you will have involvement of the ninth and tenth cranial nerves that present with drooling, feeding difficulties, difficulty swallowing, etc. Now, 11th and 12th cranial nerves. 11th cranial nerve again is difficult to assess, so you need to either do shrugging of shoulders or pushing against the wall. 12th cranial nerve, if there's no obvious tongue fasciculation or deviation, then it is less likely to be involved. Now, moving ahead with the motor examination. So, in motor, you will look at the bulk, tone, power, and reflexes. Now, remember, in all of these examinations, you will be doing it as inspection and palpation. So when we talk about bulk, how do you inspect? You look at the posture, you look at any obvious wasting or atrophy, and whether the limbs look symmetrical or not. Like I said, if it's a hemiplegic CP, one particular side will have disused atrophy, will appear atrophied and small, or there might be significant limb length discrepancy between the left and the right. So that is what you see on inspection. And on measurement, you measure the circumference of both the limbs at the same distance. So let's say you want to measure the thigh. So you decide a point, let's say 5 centimeters above the knee joint. and you measure exactly the same at the same height on both the knees and see if there's any discrepancy in the circumference of this versus that. So that is what you do when you measure the limbs, and before that we just looked at inspection. Now we saw bulk, next is tone. Now what do you mean by tone? Tone is the resistance offered to passive stretch. Remember, tone is always passive stretch. This is important because when we come to power, it's the active stretch. So that is why, remember, this is again something that is asked. Tone is resistance offered by the muscles to a passive stretch. So when on inspection, how do you assess the tone? So first is whether the muscle is lax or pendulous. If the muscle appears more prominent, it has a convexity, then it indicates more towards hypertonia. Whereas, let's say the limb is, uh, you know, loosely lying on the bed, then it points more towards hypotonia. Now, what is the posture? Is there any flexion deformity in the limbs, decorticate or decerebrate posture? When you look at palpation, how do you differentiate whether it is hyper or hypotonia on palpation? So the muscles feel strong or rigid, it is hypotonia. In hypotonia, there's restricted range of motion, and the resistance to stretch or resistance to passive stretch is obviously more if the limb is hypertonic. So that's how we differentiate whether the limb or whether the tone in the muscles is hypertonia or hypotonia. Now, having said that, only saying hypertonia is not sufficient. You need to differentiate whether the tone, which is increased when you have hypertonia, is it because of spasticity or is it because of rigidity? So, what is the difference between spasticity and rigidity? This is again very important, again, commonly asked question in your Viva. So, spasticity is predominantly a pyramidal lesion, whereas rigidity occurs because of an extrapyramidal lesion. Spasticity presents with hypertonia and hyperreflexia, whereas in rigidity, you will have hypertonia, but the reflexes are going to be normal. Okay, that's because the pyramidal tracts are not involved in a case of rigidity. Now, in spasticity, it affects predominantly one muscle group, so your anti-gravity muscle, so upper limb flexors and lower limb extensors, whereas rigidity does not have any particular selection. It involves all groups of muscles. Now, spasticity is velocity dependent, whereas rigidity is not. So, what do I mean by that? So, let's say when I talk about clasp knife spasticity. So, when you flex the elbow and you try to release it, there is resistance initially, but after a certain point, there's a give way sensation. Okay, so that is what you see in clasp knife, whereas in rigidity, you will have the same kind of resistance throughout the range of motion. Okay, and the faster you do the movement, uh, you will feel a difference in the tone. So let's say you're able to move or extend the elbow fast, uh, you will feel less resistance in a case of spasticity, whereas there is no association with the velocity of movement and the tone in a case of rigidity. So these are points how you would differentiate spasticity versus rigidity. This is, like I said, again, commonly asked Viva question. And remember, whenever you mention hypertonia, you have to always mention whether it is spasticity or rigidity on the basis of this clinical examination difference. The reason being that the site of lesion is different for both, and the kind of cerebral palsy that they both will eventually develop is going to be different. So when I say spasticity, there's this modified Ashworth scale to differentiate what grade of spasticity are we dealing with. Obviously, 0 to 4, with 0 being no increase in tone and 4 being maximum spasticity. Now, next question is, what is dystonia? And how do you differentiate spasticity from dystonia? Again, this is a commonly asked question. So spasticity, like we just discussed, is resistance to passive stretch, whereas dystonia is abnormal sustained muscle contraction. So let's say the limb, when you try to manipulate or when you try to, let's say, lift a child who has dystonia, suddenly the body will go into abnormal posturing and there'll be abnormal contraction of muscle groups. Again, like we discussed, spasticity is velocity dependent, dystonia is not. Spasticity persists in sleep as well, whereas dystonia completely disappears when the patient is asleep. Spasticity again is something that you will feel, whereas dystonia is something that you will visually see more. So these are differentiating features of spasticity and dystonia. Again, dystonia because it points towards more of an extrapyramidal lesion, whereas spasticity is because of a pyramidal tract lesion. So we saw bulk and tone. Now, what do I mean by power? Power is the muscle force that is actively generated by the muscle groups. Okay, so power again needs to be assessed at every joint. So let's say in the upper limb, you look at the shoulder, elbow, wrist, fingers, lower limb, you look at the hips, ankle, and knee joint. This is the MRC rating for power of the muscle. So remember, whenever you're mentioning examination findings of power, it has to be that what is the muscle, what is the power at the shoulder joint, what is the power at the elbow, at the wrist, at the fingers, similarly of the lower limbs. So you need to assess that again, depending on how old the patient is, whether the patient has comprehension, whether you can actually try doing it. Like for example, if you're trying to assess power of, let's say, the elbow, whether the patient is able to understand that he has to flex against resistance. So usually this power becomes a little tricky to assess in children, especially because they don't understand, they don't cooperate, and especially with those who are developmental delay. So just looking at the patient, whether the patient is able to, lift the limbs against gravity, you can say that the power of the limbs is more than 3/5 or not. Okay. Now reflexes. So DTRs, you look at upper limb and lower limb both. So you look at biceps, triceps in the upper limb, ankle and knee joint in the lower limb. You look for ankle clonus. Again, this is commonly associated with hypertonia. You have hyperreflexia. And superficial reflexes, you look for abdominal and plantars, especially whether you have or not your Babinski, positive or not. Now, gait, hemiplegic gait is commonly seen in hemiplegic CP. You have a spastic gait with scissoring of the lower limbs in a spastic diplegia. In an ataxic CP, you'll have a broad-based gait where the limbs are wide apart and there's kind of a little swaying. You look for involuntary movements like dystonia, again pointing towards dystonic CP involving the extrapyramidal lesion. In sensory, touch, pain, temperature, vibration, proprioception, and cortical sensations, out of which the easiest one to do is pain. So whether there's any withdrawal of the limb where there's a pain stimulation. Now, in older kids, that is more than 7 years of age, with normal mentation, you also need to assess for cortical sensation, which is your tactile perception, 2-point discrimination, gastroesthesia, etc. So let's say if you have a patient with hemiplegic CP with normal mentation, a 10-year-old, then cortical sensation examination also becomes an important part to doing a sensory system examination. The cerebellar functions, you look for ataxia, finger nose, finger, dysdiadochokinesia, knee heel test, pendular knee jerk, etc. So when you have ataxic CP where you have involvement of the cerebellum, you will have impairment of these functions of the cerebellum. You look at the skull and spine for microcephaly, abnormal head shape, any scoliosis, spinal deformity, tuft of hair, bed sores, etc. Primitive reflexes like rooting, sucking, glabellar tap, Moro's, etc. So when you have persistence of these primitive reflexes, so we all know that reflexes like rooting, sucking, etc. need to disappear by about 6 to 8 months of life. If you have persistence of these reflexes beyond a certain age group, then they're definitely abnormal. So why do you have persistence of these reflexes? So it can happen because of an inability to transition from the brainstem reflexes to more cortically controlled reflexes. Okay, so when you have this impaired transition, you might have persistence, which is again abnormal. So it's always good to look for primitive reflexes in a child who has CP. So at the end of your motor examination, sensory, gait, etc., next important thing to assess is your developmental assessment. So this is something that we've already done in the history taking. But over here, you will again just enumerate all the last achieved milestones under all the 4 headings. And then you will calculate the developmental age of the child. So let's say the child is actually 2 years old, but is only able to roll over from prone to supine and supine to prone. So developmental age of the child is going to be somewhere around 5 to 6 months of age, although the chronological age is, let's say, 2 years. Okay. So what important assessment you will do in a case where you're looking for development is your 180-degree flip in infants. So what do I mean by when I say 180-degree flip is first to examine the patient in supine. So you try and, lift the patient from the hands to make him from supine to sitting position. Then you hold the child vertical to see if there's slippage uh, of the body when you're holding, like in a case of hypotonia, or there's scissoring of the lower limbs, like in a case of hypertonia. Then you put the child in sitting position, and then eventually you flip the child into prone. So again, you will look for the kind of head holding, neck holding, and what is the shape of the body, whether there's flexure, contracture, etc. So that is how we do developmental assessment on the basis of examination, which is different from what we saw in the history taking part. So at the end of your CNS examination, you will also look for other systems like RS, CVS, GIT, and in just one sentence mention if there's any obvious finding in these other systems. So at the end, if you're asked to summarize this case, you will summarize all your positive history and examination findings. So examination findings, whether it is general examination like microcephaly, any obvious findings, the eye, etc., followed by CNS examination, most importantly, giving emphasis on your motor examination. So at the end of your summary, where you've summarized your positive history and examination findings, you will say that this is a case of cerebral palsy, which is a static motor disorder, okay, which happens because of an insult to the developing fetal or infant brain. Okay, so that's the definition of CP. So let's say this is the case of CP. Then you say whether it is spastic, atonic, dyskinetic, or mixed, depending on your tone assessment. That's called a physiological classification. We'll again be discussing this in the next few slides. What is topographic classification? Depending on what limb is involved. Is it hemiplegia, that is involving one half of the body, quadriplegia involving all the four limbs, diplegia involving the lower two limbs, and or monoplegia involving one particular limb? What is the functional classification in children who are more than 5 years of age? So we saw the GM FCS classification in the part one. So gross motor functional classification system is where you assess the functional classification on the basis of history. Whether or not the child has global developmental delay, what is the growth of retardation? So what is the developmental quotient? Associated comorbidities, like let's say the patient has seizure disorder, feeding difficulties, hearing impairment, GERD, microcephaly, contractures, etc. What is the developmental age? We just saw that in the developmental assessment in the examination. And at the end, what do you think is the probable etiology of this insult? Okay, so you say this is the case of CP, which is a spastic diplegia with functional classification of grade 4, with global developmental delay, with moderate retardation, with associated comorbidities like feeding difficulties and contractures in the ankle joint, the developmental age being 5 months, and most probable etiology is, say, um, a hypoxic insult, a perinatal hypoxia, because let's say that there is a history of child probably not crying at birth. So this is just an example of how the diagnosis will sound like. Obviously, it's going to be different in each case, but this is just to give you an example of what the diagnosis is. So having said that, let's discuss a few points about CP. So classification you can either classify CP as physiological or topographic. Physiological, as the name suggests, is depending on what the tone and what your motor findings are. So whether there's a spasticity, whether there's hypotonia, whether there's dyskinetic or dystonic CPY, whether you have dystonic movements, or whether it's mixed. So mixed is going to be a combination of spastic and dyskinetic. Non-topographic classification, depending on the kind of limb involvement. So if you have hemiplegia, you have one half of the body. Diplegia affects the lower two limbs. Quadriplegia affects all the four limbs, but the upper limb is involved more than the lower limb. Monoplegia is, as the name suggests, one limb involvement. Double hemiplegia is again where you have both the sides of the body, so all four limbs are involved. However, the upper limb is involved more than the lower limb. So that's how we differentiate quadriplegia from double hemiplegia. Quadri would involve the lower limbs more. Double hemiplegia involves the upper limbs more. So then these are the types of CPs you can have. You can have spastic diplegia, spastic hemiplegia, spastic quadriplegia, etc., etc. Few salient features in each of these common varieties. So when you have spastic diplegia, the lower limbs are involved more. So because you have involvement of the lower limbs, you will have scissoring or the commando crawl because of adductor muscle spasm. Importantly, they have normal mentation. Okay, so developmentally they will be fine, but they will just have a severely impaired motor component. Most common cause of spastic diplegia is periventricular leukomalacia. Again, that is commonly seen in preterm infants. Why does that happen? Why does PVL cause spastic diplegia? Is because the descending fibers of the uh, supplying the lower limbs from the motor cortex are located in the periventricular region. Okay, so whenever you have a germinal matrix or an intraventricular hemorrhage, which are common complications seen in a preterm infant or a preterm baby, you have these fibers which are located in the circumference of the ventricles getting involved first. And that is why the lower limbs are involved first in spastic diplegia because of periventricular leukomalacia. The most common problem is walking and motor deficit. And like I said, mentation is often maintained and they might not have other comorbidities like seizures, etc. Spastic hemiplegia, like as the name suggests, affects one half of the body, upper limb is involved more. Premature handedness as early as 1 year. So usually that happens after 2 years of age. But if you have early handedness, asymmetric moros, all these are abnormal findings. Common causes could be the stroke because of trauma, HIE, or coagulopathy. So many a times in the case of spastic diplegia, we might have to work up for coagulation, abnormalities, thrombophilia, etc. if that is what we find on neuroimaging. Prognosis is good and we might have incomplete or asymmetric moros. Now, spastic quadriplegia is the most debilitating variety of CP, where all the four limbs are involved. They often have associated comorbidities because they have patchy involvement in the cerebral cortex, and that is why they have associated seizures, developmental delay, feeding difficulties, etc., etc. Because a lot of areas of the brain get involved. Poor prognosis, seizures, intellectual disability, and it could either be because of PVL or multifocal cortical lesions. Chorioathetoid or dyskinetic CP is when you have involuntary movements or the chorioathetoid movements. It's an extrapyramidal lesion, so you will also have dystonias. The basal ganglion is involved. Hearing loss is often associated with chorioathetoid CP. So when you have, again, the most common cause of chorioathetoid CP is kernicterus. So, when you have kernicterus, uncontrolled hyperbilirubinemia in the neonatal period, it can lead to deposition of the bilirubin in the basal ganglion, which can eventually lead to dystonia, dystonic CP. So these infants may be hypotonic at birth, but as the time progresses, it evolves into dystonia and later involuntary movements like chorioathetosis. Okay, so this is chorioathetoid CP is different from spastic in terms of the site of lesion and the kind of presentation. Now, ataxic CP has cerebellar involvement, so they present with hypotonia with depressed reflexes. So this is important because when you have an atonic CP, that's the difference. Atonic CP will have hyperreflexia with hypotonia, whereas a cerebellar involvement causing ataxic CP will again have hypotonia, but the reflexes will be absent or depressed. So that's again how you differentiate ataxic versus atonic CP. Obviously, the level of lesion is again different for both. These are not very commonly seen varieties. We usually see spastic CP as the most common type, followed by dystonic or dyskinetic CP. Now, in a mixed CP, you will have spasticity with chorioathetosis with or without ataxia. And that's because you have pyramidal with extrapyramidal lesion causing signs of both involvement. Again, this is not so common, but again, theoretically, you should know what is a mixed CP. So based on the site of lesion, this table I've taken from Aruchami. So depending on where the lesion is, you will see what type of CP it can cause. So when you have cerebral cortical or subcortical involvement, it's mostly spastic. Again, spastic with cortical function affected if it's a cerebral cortex. So you'll have seizures with spasticity if there's involvement of the cerebral cortex. Similarly, if you have basal ganglion, it will have athetoid and dyskinetic CP. Cerebellum is ataxic CP. Global lesion, like I said, there's multifocal lesion that cause quadriplegia. So we saw this in the first video in the first part of the discussion, that what diseases can mimic CP. So you can have inborn errors of metabolism like glutaric acidemia, biotinidase deficiencies, other enzymopathies like Tay-Sachs, Krabbe's, etc. All of these can mimic cerebral palsy, and that is why they are to be considered in the differential diagnosis. So again, next, these set of questions are going to be most important for your Viva. So how will you investigate a child that you have diagnosed with cerebral palsy? So obviously the first thing is going to be a detailed history examination and assessment of comorbidities. Next important is neuroimaging. So you'll do an MRI because that's more sensitive as compared to a CT. So you want to look at the site of lesion, if there's any obvious deformation, cortical deformation, uh, then yeah, that's something that you will look for on your neuroimaging. Bera and visual assessment is something that needs to be done in every child with developmental delay. That's the next set of investigations. If you're suspecting torch, like say if you have a significant antenatal history, and let's say along with that you have other findings of torch infection. So there's cataract, there is a congenital heart disease, let's say if you're suspecting rubella, or if there's chorioretinitis, then you're suspecting CMV or toxoplasmosis, or if you only have isolated microcephaly, then you might work up for probably underlying torch infections. If the child has convulsions, then you will obviously do an EEG to look for a baseline and then follow up, especially because you're going to put the patient on anti-epileptics. And what are the indications of a metabolic or a genetic screening when you're suspecting those in a CP child? So there's a history of consanguinity, recurrent sibling loss, dysmorphism on examination, any significant family history, or if you find cerebral malformation on your neuroimaging, then you can think of doing a metabolic or a genetic screening. So these are the set of investigations that you need to do when you're working up a child who has developmental delay. Next important is how do you manage the patient? So obviously the aim of management is functional ability and independence so that they're at least able to do their daily chores on their own. So you want to address the motor impairment, treat the comorbidities, and it will always be a multidisciplinary management plan that you will make. So how do you treat spasticity? Because that is one of the most commonly associated finding in your case of CP. So again, this is commonly asked that, let's say if you have a child with spastic diplegia, what are you going to do to treat spasticity? So first, importantly, is physiotherapy. So positioning, exercises, and neurofacilitation techniques, splinting and casting the limb in a particular direction or shape. So to counteract the spastic forces. If that doesn't work, the next is oral medications, muscle relaxants like baclofen, diazepam. If that doesn't work, then you can have intrathecal medications like baclofen again to release or decrease the muscle tone. Botulinum injection, toxin injection locally, how does that work? So it inhibits the release of acetylcholine at the neuromuscular junction. So it causes something called as chemodenervation. Okay. So basically decreased ACH, decreased muscle tone, decreased spasticity. And the last thing to do if all of these are ineffective is your surgery and selective dorsal rhizotomy. But remember, these are only to be done after 5 years of age. So till 5 years of age, you try as much as you can with physiotherapy, with oral medications, or with the botulinum injection. And if all of that is unsuccessful, then what you do or what you move ahead is with surgery. So remember, if you have a child who's less than 5 years of age, you don't mention surgery because that's not something that you will do upfront. Try the other things first. Other than that, you will also do occupation therapy, speech therapy, early intervention with all types of stimulations, anticonvulsants for seizures, make sure the diet is taken care of. Also, because these patients have feeding difficulties and are nutritionally compromised, so that is why, let's say, if the child is not able to swallow, so you need to explain to the patient and the parents basically that they need to give pureed food or semi-solid food. How exactly that needs to be prepared. So often a dietitian reference is very important when you're dealing with a child who has CP, especially with feeding difficulties who's undernourished and underweight. So diet is something which is very important. And lastly, managing complications like drooling, constipation, and feeding difficulties. So I have attached the standard treatment guidelines 2022, the IAP guidelines on how do you manage each and every complication. So I don't really want to go much into detail about this. I will also be adding this link in the comment section so you can go to this, and it's a beautiful 5 or 6 page set of guidelines on what exactly CP, what are the types of CP, how do you investigate, and how do you treat. So remember, this, I mean, this is really important, very helpful. So I won't really waste too much time on this, but please have a look at these guidelines that I have attached here. Now, what are the commonly associated problems in CP? So you can have abnormal muscle tone, balance, reflexes, contractures, and hearing impairment, vision impairment, etc. So these associated comorbidities is again something that needs to be taken into account, and everything should be done in order to address these problems, because CP is something that uh, you need to aim to facilitate uh, treatment options so that the child is able to at least live a life of dignity, and at least able the child should at least be able to take care of himself on their own, at least do the basic activities. So that is why taking care of the comorbidities and the motor involvement is the most important thing that you will do in a case of CP. Now, early signs of CP, we discussed like persistence of motors beyond 2 years, I mean, beyond 6 months, early hand preference less than 2 years of age, cortical thumb or fisting. So, this is what I mean by cortical thumb. So the child has persistence of this beyond a certain age group, and again, that is abnormal. Persistent primitive reflexes, small head size, exaggerated or disorganized movements, or positive movements of one particular side. All of these are earlier signs of CP. But the prognosis depends on the type of CP, age of diagnosis, associated comorbidities, and GMFPS grade. Again, this is a commonly asked question that if you have a case of spastic hemiplegia versus spastic diplegia, which one do you think has worse prognosis? So obviously, the spastic quadriplegia, because it has more multifocal cortical involvement, has more associated intellectual disability. A spastic quadriplegia is going to have poorer prognosis as compared to spastic hemiplegia or spastic diplegia. Okay, so type of CP, age, and diagnosis. So the earlier the patient is diagnosed, more severe is the involvement, poorer is the prognosis. The more the associated comorbidities, obviously convulsions, developmental delay, feeding difficulties, contractures, seizures, etc. And higher the grade of GMFCS, that means more is the motor involvement, the prognosis becomes poorer. So prognosis depends predominantly on these features and these findings on your history and examination. So that ends the discussion on CP. So this ends our examination, investigations, treatment, and discussion with exam questions. So I hope you found this session helpful. If you have any questions or any doubts, you can always put them in the comment section. If you have any suggestions, you can also add that. And if you've liked the video, please share and subscribe and share it with the others. And see you with another video on another topic soon. Thank you.